We we will be getting started in just a few minutes at the top of the hour. We've still got a couple people joining. Thank you again for joining us this morning. I just want to check in the room. Do we have Dr. Schuster there? Oh, I see her on the Zoom actually. Dr. Schuster, are you able to hear and come off mute?
Uh, I hope so. Am I off?
Yes, you are. We can hear you loud and clear.
All right. My problem is that for some reason Zoom won't let me see my own picture in the Zoom. So I hope I'm on.
You
Is my
are. We
name
can see you
is
on
my
the top.
name is my
Yep.
name?
Yeah, we can see you, Dr. Schuster.
All
You're
right.
fabulous.
Thank you. I sometimes get logged in for a good friend who lent me her Zoom during COVID, and so sometimes I show up as Nicola Foreman, and then people think I'm trying to travel incognito. So just double checking on that.
Good morning.
And there's Emily and Barbara's on, I see, and some of our Alterum folks.
Zach's here too. I'm on Zoom.
Oh, good.
Wonderful.
Yeah.
Mhm.
Good to see you, Zach. And I
Good.
see, oh, yeah, I see our esteemed secretary is on. Great. Hi, Aisha. And Susan Stewart and Eric Wright. Great.
So Barbara, I'm hoping also, could you please make Emily Beauregard a co-host? I believe she'll be presenting a report out at her section of the agenda and might have slides that she'll want to share as well. So if you could make her a co-host, that would be wonderful.
Thank you, Helen. I am going to be speaking, but I don't have any slides this time.
Oh,
I might
okay.
next time.
Okay, thank you. All right. So Dr. Schuster, are you ready to get started?
Is it the magic hour of 10 o'clock?
It's 10:01. We
Ah,
have a couple housekeeping items just to flag real quickly. For those of you in person, thank you so much for joining. You're on mute, and I know that you'll be managing that closely, so thank you so much. When you do wish to speak, we can see you, but we do welcome you all to just speak up and let us know that you have a hand raised so that we can see you clearly. And then again, please speak loudly so that we can all hear you. And it's also sometimes helpful to say your name when you're noting who's talking. And then for those on Zoom, please do stay muted unless you wish to speak. And you can use the raise hand feature. It's a reaction in your bottom options. And we would love it if possible for you to have your camera turned on, but we understand everybody is coming to us today from different situations. So we understand if you are not able to. If you have any questions during the meeting, please feel free to use the chat as well. If you prefer not to raise your hand and voice the question at that time, we will be monitoring that closely. And with that, I can turn it over to you, Dr. Schuster.
thank you very much, Helen, and good morning. Welcome to you all. I will call the meeting to order at 10:03 or whatever it is on February the 5th, 2026. I'm Dr. Sheila Schuster. I'm a psychologist. This is, I think, my third year of being on the MAC, and I have served previously as the chair. And I also chaired the Behavioral Health Technical Advisory Committee. Our vice chair, Dr. Beth Parton, is not able to be here today. She had clinical obligations and couldn't change those. But I welcome you all, and I'm going to call on our secretary, Aisha. Well, let me make one reminder. We do have public comment period. That's part of the requirements from CMS. So if you would like to make a public comment, those of you who are not on the MAC, if you would put your name in the chat and write by it public comment, we will take the first 5 people that sign into the chat. We've allocated 15 minutes and we'll give you each up to 3 minutes. But we are welcoming, we're going to do this a little bit differently for our meeting in April. But since we were doing this quickly before this meeting, I just wanted to remind you of that. And with that being said, I'll turn it over to our secretary, Aisha Elam to call the roll, please.
Yes, ma'am. My name's Aisha Elam, and I will be doing the roll call. Dr. Sarah Moyer,
Here.
Kendra Marsh, Kendra Marsh, Susan Stewart,
Here.
Heather Smith,
Here.
John Dadds, John Dadds, Dr. Kelly Evans,
Here.
Dr. Beth Parton.
She's not going to be here, Aisha.
Okay.
Yeah,
Thank you. Dr. Catherine Hanna.
Here.
Thank you. Philip Travis. Philip Travis. Okay. Dr. Justin Colasa. Dr. Justin Colasa. Okay. Nina Eisner.
Nina here.
Oh, thank you.
Sure.
Barry Martin. Barry Martin. Kent Gilbert.
Here.
Mackenzie Wallace.
She
Mackenzie.
texted me, she may be a minute or two coming on late. We'll look for Aisha, but she texted me and said she's in
Okay.
Frankfurt, but is trying to get onto the meeting. Thank you.
Okay, thank you. Dr. Sheila Schuster, I see that you're here.
I'm here.
Ronald Butler. Ronald Butler. Brian Proctor.
Here.
Peggy Roark. Peggy Roark.
I think she had a conflict with another meeting. She was going to try to join us later. Thank you.
Okay. Tanya Whitfield. Tanya Whitfield.
I thought I saw that she made a comment. No, she didn't make a comment in the
No,
chat.
that was Theta, I think.
Yeah.
Yeah.
Never mind.
Theta Simpson Mosby. She made a comment, you said?
Theta
I'm
did
here.
not tell me. I'm sorry.
Thank you.
Yeah, I'm
I'm not
here.
trying to confuse people. Sorry, Theta.
It's okay.
Emily Beauregard, you are
Here.
here. Eric Wright. Eric Wright.
Now,
Yeah, I'm here.
Eric did make a comment in the chat, and it sounds like he's on.
Zachary Hart.
I'm here.
So that looks like everyone is.
Well, I think you should call on the ex officio members. Do you have that list?
I don't see it.
Sorry, I joined a little late. This is Philip Travis. I'm here.
Okay.
Great. Thank you, Philip.
Sorry.
I can see if it was sent in a separate email.
Helen, do you have that the listing of the ex officio members? Because it seems like we ought to have them.
Yep,
Know
we
whether
can
they're
call
here
on
now.
that. Commissioner Lee,
Here.
Dr. Langefeld, Dr. Marks,
Present.
Commissioner Dennis.
Danielle Corey here for Commissioner Dennis.
Thank you. And then Taben Harrington.
Present.
Great. Thank you. All right. So it looks like we have a quorum. I'm just doing a rough count, but it looks like we have a quorum to do business. So I appreciate, thank you, Aisha, for doing the roll call. Does anyone have any conflict of interest? And if you do, you feel free to raise your hand now. If you are present for the discussions, then you're acknowledging that you don't have any known conflicts of interest. So it's one reason that we send out the agenda early. So if you have a conflict, if you would raise your hand.
I also want to acknowledge that Mackenzie Wallace has just joined. I just let her in from the lobby.
Ah, great. Thank you.
Thank you.
Welcome.
All right. Then next will be the approval of the minutes of our meeting of November 3rd, 2025. And those minutes were distributed by the Alterum Group with a number of other documents for you to review. So
I'll make the
would-
motion. This is Nina Eisner. I'll move
Thank
to
you,
approve the
Nina.
minutes.
All right, and a second, please.
Second.
Susan Stewart, I'll second.
Susan Stewart, thank you. If we could get your name when you do that, that would be helpful. Anyone have any additions, corrections, omissions that they would like to bring forward?
I like the abbreviated format.
It's a lot easier to read than the
Yeah.
court report, right?
I agree.
Yes.
So then we'll call for a vote of all of the voting members of the MAC. All in favor of approving the minutes signify by saying aye.
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 And opposed and abstaining. All right, the minutes are approved. Good job there, Aisha.
Thank you.
They really are so much easier to read. So we have a couple people in the chat, Aisha, if you might monitor that, who are have gotten in a little bit late and are want to be recorded as being here.
Okay, I'll keep an eye on that.
you.
Thank you.
So we discussed these bylaws, and the complete set of bylaws went out to you also for your review. And then there's some new sections here that are on the screen, and it has to do with the technical advisory committees, and talks about their establishment and how they will make their recommendations. It is the responsibility of the MAC, the Medicaid Advisory. I have to get used to saying Medicaid Advisory Committee because we're no longer a council, to accept the recommendations from the tax. And our job then is to send them forward to the Department for Medicaid Services so that they can respond to them. We're technically not actually approving the content. We don't have debate and presentations on the content, but we are simply acknowledging that those recommendations were made at a regularly scheduled meeting of the TAC where they had a quorum present. And so we are accepting them and then moving them on to DMS. And so the rest of the information about the tax is listed there on the screen, and it's included in the document that was sent out to you all. So I would entertain a motion for the approval of the bylaws for the MAC.
So moved.
Who's that, please?
Ken Gilbert.
Thank you, Kent.
This is Emily Beauregard. I second.
And Emily seconds. Thank you very much. Are there any questions, additions, corrections to those bylaws? We had quite a discussion about them and made some changes at that first meeting. All right, hearing none, then I will ask for a vote of all the voting members of the MAC. Please vote aye if you are in favor of approving our bylaws.
Aye.
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 Thank you. Any nay votes by the same sign? And any abstentions? Great. We are approved. We're official. You're only official, I guess, if you have bylaws, right? And thank you to the Alterum team for their assistance in working through those bylaws. So one of the new facets of the MAC is the inclusion of in our membership of some members of the BAC. That's the Beneficiaries Advisory Council. And their chair is Emily Beauregard, who is on screen. A report of their meeting in January was sent out, so we got that in writing. And again, easy to read and follow minutes, which we approved. But Emily, I want to turn it over to you to tell us a little bit about the BAC. And you've had 2 meetings at this point. And yeah, I'd really like to. And Veronica, before you start, Veronica Judy Cecil said the updated bylaws will be sent out to all members and then posted on the MAC website. Thank you, Veronica. And Emily, I'll turn it over to you.
Well, thank you, Dr. Schuster, and good morning, everyone. As you mentioned, Dr. Schuster, we've had 2 meetings of our newly appointed Beneficiary Advisory Council. We held our first meeting last October with a quorum present. We welcomed a 15-member council made up of 8 current Medicaid members, 2 former Medicaid members, and 5 family members. And I happen to be one of those family members. The BAC was established, just as, sort of context, background for everyone. The BAC was established to advise DMS on Medicaid program policies and operations, including service changes, eligibility and renewal processes, communication practices, cultural needs and language accessibility, equitable treatment, and overall access to quality care. So during our first meeting, we adopted bylaws. We voted on officers. My fellow officers include longtime MAC member Eric Wright as our vice chair and Kelly Jo Blair as our secretary. DMS also provided us with an overview at that first meeting of the federal changes that are being made as a result of the One Big Beautiful Bill that became law last July. And we had an overview of the HCBS waivers, which are incredibly important to the Medicaid program overall, and particularly to many of our BAC members who are family members or beneficiaries participating in one of those waiver programs. So in getting started, the Alterum team reached out to every member individually to make sure that people understood their role on the BAC, had an opportunity to ask questions, to share their priorities. And before each meeting, we are surveying members to ask for topics of interest, for questions they may have about Medicaid policies and services. So some of the initial topics of interest have included improving the Medicaid application process and customer service, simplifying Medicaid information for recipients, ending the waiver waiting list for those home and community-based services, and also improving those services, and making exceptions to the electronic visit verification process when technology fails. We often call that EVV. And then discussing medical cannabis. Those are the topics that have come up so far. We held our second meeting on January 12th with a quorum present, and we shaped our agenda for that meeting around a few of the topics that I just mentioned. And one of those kind of an overarching topic that we focused on for that meeting was the use of human-centered design in the implementation of new federal requirements in the Big Beautiful Bill. So thinking back to those areas where people said they wanted to work on the application process, simplifying information for consumers, that's really where human-centered design comes in. The philosophy behind human-centered design is that you build systems like Connect or design forms around the needs of the user and making them as simple and easy to navigate as possible. The cabinet has made a lot of effort to apply these principles to Connect over the years, but often fails short in integrating beneficiaries into the process. And that's where the new BAC can really contribute. And we discussed the need for DMS to create a process for working with the BAC to apply these principles of human-centered design to policy and system changes, particularly related to outreach, eligibility, enrollment, and renewal. And what we'd like to see happen early this year is that beneficiaries be included in some of the planning discussions around how the application and renewal process will change to incorporate those new requirements for community engagement, work reporting, and exemptions, that kind of paperwork that people will have to now start completing. And once those system changes are being designed, beneficiaries should be reviewing the new screens, providing feedback on how clear the information is, how intuitive the screens are to navigate, And similarly, it's going to be very important for beneficiaries to provide input into new notices for community engagement, for the exemptions, for the 6-month redeterminations. It would really help us, I think, ensure a better product and a better process that will reduce churn, ongoing. In addition to that, it really actually also it makes it easier for the beneficiary, but it also reduces the workload on staff, and I think that's important to keep in mind. So at our January meeting, in addition to that discussion, we also spent a good amount of time learning about HCBS waiver waiting lists and clarifying some conflicting information around eligibility for Michelle P. waiver that was based on intellectual and developmental disabilities. That was where the question and the sort of conflicting information arose. And then one back member specifically asked for guidance on what could be done when those EVV verification of visits technology fails. So in the case of a power or an internet outage, which, coming off 2 weeks of snow and ice, I think is pretty clearly an issue that many of us have to face from time to time, or another type of disruption to the usual EVV process. So we're hoping to get that guidance soon. I think that could be really helpful to a lot of families with waivers. And then another back member raised a policy concern regarding the potential for a waiver recipient to lose their slot due to a conflict that was created by their employer or employee, or their representative. So this individual was speaking from personal experience, having been the one to make the mistake that cost her son a waiver slot. And that led us to make our first official recommendation, which I did submit, but the recommendation is that there be a change to the policy so that waiver participants do not lose their waiver slot due to the actions of an employee or representative. This member said, that employee or representative should be fired or replaced, but the waiver slot should not be lost. And while we initially agreed to meet every 2 months as a back, we quickly realized that members may need additional meetings to learn about certain policies or programs, ask questions, provide input. So for that reason, we're planning to offer an office hours type of session in between our meetings to provide that extra time and attention to specific topics. So that first meeting will be focused on HCBS waiver waiting lists, just as a continuation of the discussion that we already started in January. So we have a current meeting schedule for every other month. Our next meeting is March 9th. At 2 p.m. Right now, these are our business meetings and not the office hours that I just mentioned. But these meetings aren't open to the public at the moment. It's an option that CMS allows to be sensitive to the comfort levels of beneficiaries. So unlike the MAC and the other TACs that are all subject to open records or open meeting rules, the back can meet privately, but we will be taking a vote on whether to make some future meetings open to the public as appropriate, and we'll be sure to let the MAC know if any of that changes. And I'd be happy to answer any other questions.
Yeah, let's see if there are any questions from the MAC members. And since I can't see everybody, how about just unmuting yourself and asking a question of Emily if you've got one? I have one actually, Emily, because I'm trying to figure out what a good working relationship between the BAC and the MAC is. It's great to have you and some other members of the BAC serving on the MAC, but I actually wondered if you all might, as a general agenda item, see if there are any recommendations from the BAC to the MAC for things that you might want us to put on our agenda or respond to. Does that make sense?
Yes, I think that's a really good suggestion, and we can make sure to put that on the next agenda and just have more of a conversation around, like you said, what is the relationship? BAC members now make up just over or exactly 25%.
Yeah, I think it's
the MAC
right
membership,
25%, right.
Which is significant, and we absolutely do want to make sure that we are providing the kind of input and expertise that we can to the MAC's work.
Well, and since you all meet a month before us, it works out, I think, timing wise. As you know, we're on a shorter time frame to have our meetings be 2 hours rather than 3 hours. So, we'll see how that works. But I'd like to extend that invitation to the back. I think if any of the other back members who aren't members of the MAC want to monitor the MAC meetings, we always talk quite a bit about the waivers and the waiting lists and so forth. So there certainly is some overlap there. Any other questions from any of the MAC members about how the BAC is operating or what their goals are?
Yeah, I just had a quick question.
Yes, Tanya.
Yes, I know like a lot of y'all pretty much broke down everything, but me, I'm more of a auditory learner. So I just want to kind of know like what the actual role is that I will be participating in, if that makes sense.
As a MAC member?
Yeah, and I'm a Mac and back, so
And you're
yeah.
okay. So you're
Yes,
a
ma'am.
dual membership. That's a really good
Yes,
question. I don't know that there's any formal guidance, at least not that I'm aware of, from CMS. But having back members on the MAC certainly broadens our perspective in our discussions, and certainly I don't know beyond that. Do you have any thoughts, Emily? Because you have monitored the MAC meetings for a long time. Excuse me.
I think we don't have a lot of time for discussion with the MAC meetings, which is the unfortunate part of the limited time frame and all of the different topics that we want to address. And so it may be we're going to be testing out this office hours concept. I don't know if if there are other opportunities for discussion more than just presentation. But when you say auditory, it makes me think it might just be that more interactive sort of participation that some people want. And so I can give that some thought, but I'm hoping that beyond just these meetings, the MAC and the BAC meetings, that there will be other opportunities for beneficiaries to, review certain forms, certain screens, to go over what a process is going to look like and have some input there. And I think that that's where we really start to have an impact.
Yeah. Tanya, I'm so glad you asked that question, and I want to really encourage particularly those who are new to the MAC, and especially those of you who are BAC members now on the TAC, to ask those questions. And I think Barbara or Helen, if you would put my email address in the chat for people, it's real easy to remember. It's kyadvocacy@gmail.com. I am more than happy to respond to you by email or talk to you on the phone if there's some questions that you want to bring up anytime. I think the other MAC members know that I'm try to be pretty available, and people contact me with items for the agenda and so forth. But I'm so glad you asked that question. I appreciate that. And I will tell the MAC members that we didn't do it for this meeting because we have not had a real business meeting of the MAC since May of last year. That we were suspended during the period where from July 8th or something like that until the BAC could get together and meet. And then that first meeting of the BAC and the first meeting of the MAC were really kind of getting up and running and electing officers and setting guidelines and doing the bylaws and so forth. So we had so many carryover items that we have typically had on the MAC agenda that I sent out the agenda when it was pretty well done and said, does anybody have anything else? But I really like your idea, Emily, of kind of polling people in a more deliberate way to see if they have some suggestions. So I will try to remind myself to do that. Appreciate that. If there,
Dr. Schuster?
yes,
This is Veronica, Judy Cecil, Senior
Yeah.
Deputy Commissioner of Medicaid. I will say that part of the reasoning behind the federal changes was to make sure that the Medicaid Advisory Committee had that voice of the member at the meetings, because a lot of states varied in the representation of the MAC and the stakeholders who were on it. And so, Tanya, I really feel like what CMS wanted is to make sure that beneficiaries had that voice. And we encourage you all to ask questions and to, participate fully. We're here to support that, the reason behind the changes. We really want to hear from those voices.
Yeah, thank you very much, Veronica. I think that is also helpful. And again, thank you, Tanya, for raising the question. I might also say, just by way of historical reference, that if you look back at the MAC agendas toward the end of 2024, those last two meetings and the first two meetings or three meetings in 2025, we had a regular agenda item of how can we make Medicaid more known to Kentuckians? How can we get people to understand what Medicaid has to offer, and particularly what Medicaid waivers have to offer? So the MAC was very concerned, because I had been hearing, and I know Eric Wright and other people that work closely with beneficiaries were hearing, moms of kids that are born with disabilities, and they don't know anything about the waivers until they happen to meet another mom who says, oh, well, you should get your child on a waiting list for one of the waivers. And they're like, what's a waiver? What's Medicaid? That kind of thing. So we have been concerned about that. And I'll be really anxious to see what kinds of recommendations you all have in terms of simplification of the application and those kinds of issues. I think that's been something that the MAC members have been very interested in addressing as well. So let us move on. I'm not going to be very good at keeping in our time frame that they've set for me. So let me move on to the commissioner updates. And Commissioner Lee, we're so glad to have you. I can barely see you. You look very tiny on my screen.
Good. The camera's not adding 10 pounds then.
No, it's not. But I was in person at the first meeting, and I decided I couldn't see the screen because we were seated so far away from the screen. I said, I've got to go to Zoom. So welcome. And you have the floor for a whole number of things that we have listed for you. So take them in whatever order you would like to do them. But the floor is yours.
Well, thank you. Thank you, Dr. Schuster. Again, I'm Lisa Lee. I'm the commissioner for the Department for Medicaid Services. I've been around for about 25 years. For those of you who I haven't met yet, welcome and so glad you're here. Thank you so much for your commitment to the Medicaid program and helping us ensure that we're building a healthier Kentucky. The Department for Medicaid Services is a department within the Cabinet for Health and Family Services. And our mission, or our vision, is a commonwealth where every Kentuckian reaches their full human potential and all communities thrive. And the MAC in the back helps us do that by bringing your personal perspectives, your concerns, issues that you have, that you've identified either through your own personal experience or through others who are in the program or who have interactions with the program that you talk to. So just going back to Tanya about what you asked is just talking to us and being very open and honest about issues and concerns that you have with the Medicaid program, because our role here as a body, as a group, as citizens of the Commonwealth is to build a healthier future for this state. And so if we could go to the next slide, please. I think that we do that. I think I always like to give a little Medicaid at a glance so we know what we're dealing with this program and how very important it is to the state of Kentucky. we currently serve over 1.4 million members in the Medicaid program. Over 600,000 of those individuals are children. And currently the state has about 1.1 million children under the age of 18 in the state. That means that over half of those children are being served by Medicaid or the Kentucky Children's Health Insurance Program, or KCHIP, which gives us a really good opportunity to build a healthier future with starting with their children and making sure that they're getting the services that they need. We have over 450,000 expansion members. Those are members who are between the ages of 18 and 65 and who typically prior to 2014 were not enrolled in the Medicaid program. These individuals have to be at or below 138% of the federal poverty level, which is about, I think, $20,000 a year for one person. We currently have approximately 75,000 enrolled providers serving our population, which is both in-state and out-of-state. And in fiscal year 25, we spent $20.6 billion delivering healthcare services to those 1.4 million members. Next slide, please. Just to give you a little bit of a Medicaid enrollment trend, as you can see in 2000, we had a little over 1.3 million Medicaid members. And then you can see the big spike from 2020 to 2021. That was during the COVID public health emergency. During those several years following, we were not allowed to disenroll individuals unless they moved out of state, they requested to be disenrolled, or they passed away. Starting in 2023, with the end of the public health emergency, we started doing recertifications, and that's what happened when we see that drop going down into 2025. While we're not at our pre-COVID levels, we are about 1.4 million individuals. So you can see we have roughly grown this program over those years to a little over 100,000 individuals. Next slide, please. So I just wanted to put this out here. We do serve, you've heard some conversations about waiver members and waiver programs. So we sort of have two different populations in the Medicaid program. We have waiver individuals that we call fee-for-service because those individuals are not enrolled in a managed care organization. So those individuals are in a waiver program or in long-term care. And I think that we have a little over 100,000 individuals in those two programs that fee-for-service as a whole. It includes different categories of service. But what we look at on a monthly basis, we get information, as you can see here. These are the top 10 procedure codes for December of 2025. Now, I'm not going to go through all of those, but as you recall, I just said that our fee-for-service population is waiver and long-term care. So this gives you an idea of the services that those individuals receive. And as you can see, it is services that helps them remain in their home and community rather than being in a long-term care facility. And we have listed these by the top 10 procedure codes by the amount of money that we pay for the claims that come in. You can see how many distinct members receive those services and the claims. And I think this is really important information for us to see the types of services that individuals are receiving. The next slide, please. Here you can see the top 10 diagnosis codes for individuals who are enrolled in our fee-for-service program. Again, I don't think a lot of surprises here. You see autism, you see COPD, you see some intellectual disabilities. Again, and these diagnosis codes are based on the amount of money that we spent that month. This is, again, December 2025 for that specific diagnosis code. It shows how many members and how many claims came. Next slide. So now we turn to our managed care organization and the individuals that they serve. They serve approximately 90% of the Medicaid population. And again, you can see the top 10 procedure codes, emergency visits being the top 2. You can see the amount of claims paid, members, and so forth. Again, we'll not go through every one of these, but you all will have these slides and you can look at them at your leisure and see if there's anything else you want to look at or dig down into. with any of these procedure codes. Next slide. Here you can see the top 10 diagnosis codes for our or managed care organization members. And you can see these are totally different than our fee-for-service population. And the reason that I wanted to show this is when people look at the Medicaid program and they think about the Medicaid program, they just think of Medicaid and they don't really see those. There's two distinct populations that we are serving and they have very distinct needs. Now, this is just managed care and fee-for-service comparison. We haven't even gotten into the the children versus adults. And so the population is very diverse and each population has very specific needs and have different medical conditions. Next slide. Our budget, this is Steve Bechtel, our Chief Financial Officer, and I testified before the, I think the Senate Budget Review Committee last week. As you can see in 2027, our governor's recommended budget is laid out here, but 359. This is our administrative budget, $359 million plus some change for 27 and 335 for 28. Included in this budget is a 2% cost of living increase for staff. It also has administrative costs for us to implement provisions in House Resolution 1, specifically related to community engagement. Next slide, please. And this is our benefits budget. Our benefits budget in 2027 is going to be roughly over $22 billion. This is the governor's recommended again. And in 28-23, the governor did include 500 new waiver slots for Michelle P. In 2027 and 250 waiver slots for SCL in 27 and 500 for the HCV waiver. Next slide, please. Next slide, please. I'm going to stop with the slides right there for a minute and go into just some other information before we hit the rural health transformation program. So I've given you a little bit of the Medicaid overview and the funding as we move forward. I also want to just talk a little bit about the Medicaid Oversight and Advisory Board findings and recommendations. You know, there is a Medicaid Oversight and Advisory Board that was formed in the last legislative session that meets on a routine basis, discusses the Medicaid program, and talks about ways to improve and increase oversight of their program. So at the last meeting, there were several findings and recommendations, and I won't go into all of these, but we will send you, if you don't have those, we will send a link to the findings and recommendations again so that you can read them at your leisure. Some of the recommendations state that that we will tighten and modernize eligibility processes. Some of this goes into alignment with House Resolution 1. Making sure that individuals that we don't have duplicate enrollment, sometimes that happens, or concurrent enrollment in other states, just basically looking at our eligibility processes. And there was a recommendation to clarify and streamline overlapping HTVS waiver services to reduce duplication, simplify provider contract, and standardize processes across programs and contractors. Now, how these recommendations will be implemented, I think will be discussed at future MOAB meetings. All of those are open to the public, and they do have an opportunity for individuals in the public to come and discuss. Another recommendation was around workforce participation, specifically stating that we would be in compliance with HR 1 as it relates to workforce development, and that we would monitor enrollment. Going forward, we will be implementing, based on HR 1, we will be implementing some cost sharing measures. As you know, Medicaid did have some cost sharing prior to the COVID public health emergency. We relaxed those cost sharing provisions, and then they were actually eliminated with a bill that was passed several years ago. And now, based on HR 1, we will have to re-implement cost sharing provisions. We are looking to see how we can make those policies as least impactful as we can on both our members and providers. Because federal rules state that any amount of cost sharing has to be deducted from the provider's reimbursement. So for example, and this is not, I'm just making up a number right here. If we had a $1 copayment on pharmacy, for example, we would have to reduce that reimbursement by that $1. If we had a $20 copayment on emergency room usage, we would have to reduce the hospital bill by $20.
So just to be clear, that means that the provider will have net zero effects on the provider payments. Is that right? If I'm the provider, I get the same amount, but the CMS will deduct
That's correct.
the copay what they're getting from the
From the
member.
member, and that is in the event that the member can pay the copay. So we will have to be very cautious about how we develop policies regarding to members who may not be able to pay that copay as we go forward. There was a recommendation regarding the Rural Health Transformation Project. I'll talk about that that project in a little bit. There were some recommendations related to tax changes and state directed payments. And this is specific to providers. We believe that we are in compliance with the tax changes that were outlined in HR 1 for the most part. The bigger concern, of course, is our state directed payments. Right now, we have several state directed payments that allow us, for example, to pay hospitals the average commercial rate. Those amounts will be reduced going forward until hospitals are reimbursed at 100% of the Medicare rate. This will be a pretty significant decrease in funding to hospitals. That's one thing we're definitely keeping an eye on. There were some other findings and recommendations regarding oversight and monitoring of the Medicaid program in addition to MCOs. And again, we will send you a link to all of these recommendations so that you can read them at your leisure if you have any questions. And we talked a little bit about House Resolution 1 updates with the MOAB update. Our main priority as we move forward is being in compliance, of course, with HR 1, which states that we have to have a community and work engagement in place by December 31st of this year. That means we have to have our system ready no later than September 1st, I think, of this year. So that gives us a very, very condensed, shortened time frame to get our system ready, to be able to inform individuals that will be subject to working community engagement activities to make sure we're in compliance with HR 1 as it relates to community engagement. And as it relates to that, we've also been keeping an eye on and monitoring legislation. For example, House Bill 2 that has been proposed does have some community engagement language in there, and it even shortens the timeline, I think, to a July 1 compliance date. And I know, Emily, you talked about the beneficiaries and the boys having their voice and them participating in our system design and notices, and we are going to make every effort to make sure that happens. But I think what is important to note is CMS, the Centers for Medicare and Medicaid Services, who is our partner in the Medicaid program, has said, we understand that this is going to be a condensed time frame. We understand their issues. And they haven't even provided us with the final rules related to community engagement. However, they have given us information that will allow us to build a minimum viable product, an MVP, and it is not the typical MVP definition. Again, it's minimum viable product. So what we anticipate is building our system, getting in compliance with federal rules so that we have no risk of losing any federal dollars, being in compliance. CMS has said we can take self-attestation for a year. Now, there was some language in House Bill 2 related to that. We really need to keep an eye on how that works out, because we believe that self-attestation is going to be so critical for that first year so that individuals don't lose their eligibility in Medicaid. And as we build that system, we get our minimum viable product. That's when we're actually going to start seeing a lot of work, and we're going to have our members testing systems and looking at how we design everything going forward for our members to be able to verify that they are meeting those requirements. Now, the good news to all this is that the state and the state Medicaid agency has to do everything we can to confirm compliance with those community engagement activities, so we can reduce the burden on the member of having to supply any documentation. So, for example, if we have access to our SWICA data or state wage index data, we can confirm they're working, they've got money, the members will not have to do anything. We will continue to make sure that we are doing everything we can to assist them, because our overarching goal, of course, is to keep everyone who is eligible enrolled in a Medicaid program. And second, we want to connect individuals with community engagement activities that help them meet those requirements. So the last thing I want to talk about is the Rural Health Transformation Program. As you know, Kentucky was awarded $212.9 million for the Rural Health Transformation Program. This initiative is being led by the Department for Public Health, that is Dr. John Langfeld and his team, and they are doing a fantastic job. We have the funding is restricted. That means we cannot use the funding that we receive for anything other than those items that were outlined in the notice of funding opportunity and our application. And I think we'll put a link in the chat too that will take you to a web page that contains all sorts of information. It has the application, and it has a lot of information about where we're moving with the Rural Health Transformation Program. There are 5 big priority areas, which is rural community hubs for chronic care innovation. That's going to be like a local hub and spoke network focused on preventing and managing chronic diseases. We're also going to have a powering maternal and infant health a component, which is going to be telehealth enabled community teams are going to expand prenatal and postpartum care. Rapid response to recovery, which is an impact model. That's one that already exists. And if you're very interested in that, I would think that Commissioner Marks may be able at one of the upcoming meetings provide a little bit of information relating to the impact and behavioral health that's going to have an impact on our behavioral health. We have a rooted in health component, which is rural access to dental care, and then crisis to care, which is integrating EMS response. So I don't know if I've got my 35 minutes in or not, but I'm going to stop right there. That's a lot of information to throw out. Just see if you all have questions or anything that we can help you with as it relates to any of the topics I just touched on.
Thank you very much, Commissioner. I noticed that our Mackenzie Wallace, who's with the Alzheimer's Association, is a MAC member, and said that the rural health transformation seems to lack any aging focus. They presented, Dr. Langfeld presented yesterday, Mackenzie, at the Budget Review Subcommittee on Health and Family Services, and Dr. Lisa Wilner, who's a psychologist and representative from Jefferson County, asked that very question. It was very interesting. And what Dr. Langfeld said was that each of those buckets, if you will, or each of those focus areas go from, with the exception probably of maternal and infant health, cover the lifespan. So they are not certainly ignoring the aging population, although they don't have a bucket that is just on that. And that was kind of her question, because we know that, and I'll speak for myself, not only are we all getting older, but certainly the number of our elderly is growing. But that was his response to it. I just wanted to respond to your item in the chat. Are there any questions for Commissioner Lee? And she covered lots. You're going to get those slides, because I think the data slides, I think Commissioner Lee comparing the fee-for-service, which is the nursing home and waivers, compared to the managed care organization, which is kind of the rest of the world, are very interesting to look at in terms of those differences in the different populations that they serve, and just the sheer amount of money that's coming in and out of Medicaid. And speaking of money, I'm sure you all at the cabinet have looked at House Bill 500, which is the House's version of the budget. And you see that there is very little money actually contained in there. The process is that they are asking people to go to those budget review subcommittees. And I will say, for those of you who are interested in the waivers, that our waiting list is now up to, I think we're going to get this number here in a little bit from Veronica Judy Cecil, up to over 16,000. None of the expanded slots or placements the governor had in his budget are in the House budget so far. There's no money for those additional slots. So I just bring that to your attention. Any questions from any of the MAC members of Commissioner Lee about the things she reported on, or other things that you would like to hear from her at some point?
We have one in here in the room.
Dr. Schuster?
Yes.
If I might, I did some quick looks at the costs per, for example, emergency room visits. It seems to me that this is incredible value for money. I mean, I don't know what your take is, and I'm sure that there are variations across the board, but there's been so much focus on worries that there is some huge leak of money. As I look, just quick numbers here, I'm seeing that we're getting incredible help for extreme value in these monies. I mean, do you have comments about, are there areas where we're not getting that, or where you have concerns? Because I don't see that we are overpaying, and I'm pretty sure providers on the call will agree that we're not. But as far as getting help for the dollar, it looks to me like this is an incredible deal.
And you too, when you look at that, you know that the dollar amounts you're looking at, almost 80% of that comes from the federal government. So a little over 20. And I think I wanted to show that information too, to let you all know what's out there, what we have, because the MAC in the back is going to be so important in helping us. You know, one of the problems that we have is we have so much information. And I know at one of the MOAB meetings, a comment was made that we've had this process in place for several years and we're not showing any improvement in healthcare. Yet we know that our suicide rate has been reduced. We know we're making strides in our behavioral health area. We know we are making improvements. We look at America's Health Rankings. We went from 47, I think we're the 41st, and now we're back down to 43. But what do we need to look at, and how do we tell the Medicaid story? How do we show that the Medicaid program is making great strides in improving the healthcare of the state? And how do we keep that momentum so that those individuals who maybe see the program as ballooning out of control actually see the value of the program and what we are doing? And how do we make sure that we give information to all of those who are making policies to ensure that this program remains viable for future generations? Because we see what's going on with HR 1, with some of the cuts that will be made to the hospital segment, that it's a little bit concerning, because when you see that they're going to be going from average commercial rate down to 100% of Medicare. Now that 100% of Medicare is in expansion states. Non-expansion states will be allowed to pay 110% of the Medicare fee schedule for those services that are covered by Medicare, because not everything, Medicare and Medicaid do not always align. Yes.
Yeah, thank you. I see Eric has his hand up. Eric?
I just want to say thank you, Commissioner. You know, we always appreciate you and your partnership and how you work hard for the citizens of the Commonwealth. And we know it's a tough task, but one that you've challenged and worked with for many years now. I've been keeping up with a number of dialogues across the country related to Medicaid, and particularly renewals and individuals that are on waiver programs. I'm hearing some recent dialogue that there are what's being called drops, automatic drops, and I'm hearing this. I heard this in Colorado most recently with some friends of ours who have a child with Angelman syndrome, and then we follow those social media posts. I was hoping maybe you could speak to that. What are you hearing? What's the national kind of discussion amongst commissioners across the country related to those type of circumstances? I'll just stop talking and let you maybe answer.
We do have routine conversations. We have meetings with various Medicaid directors. For example, we have a South Region Medicaid, I don't know if we call it a club or whatever it is, but we have a meeting with all of the Medicaid directors in the South. And while I'm familiar with some of the things that are going on in Colorado, our conversations as it relates to waivers is really not about the enrollment piece in it. It's more about how do we get those services to members. And there's a huge conversation right now on children, waivers for children and what we're seeing there. But I'll be more than happy to take that back and see what I can find about those conversations related to specifically decreases in waiver enrollment. Because I don't think that we're seeing that here in Kentucky.
Thank you, Commissioner. Tanya, you had your hand up.
Yes, ma'am. And I don't really know if this is what we do, but when it comes to the community, because I feel in my understanding, and correct me if I'm wrong, like we kind of are representing our community. And so for me, like, I just want to be able to like understand as much about this process as possible. So it's like a level of, I want to be able to know the terms and things because I want to make sure I'm saying it correctly in certain conversations, but I also want to make sure that not only am I understanding in regular terms, but when I'm sharing with other people, because, you know, I'm in the community a lot and people are always asking me questions about things. And so, and everybody's learning is at different levels. So I just want to make sure that like I'm explaining it the best way I know how without like not dumbing it down, but where I can understand it, but also like depending on what room I'm in, you know, I want to be able to have all the levels, if that makes sense. So I know that's a long question, but just, you know, I just, like I said, I just want to make sure I'm representing as well as I can and never wanting people to feel like we're dumbing down things for them, but where they're able to understand, but also because me, if I get confused, I ain't got no problem telling y'all that. But you know, not everybody wants to say that. So like just making sure that I'm actively communicating you know, the best way with the best information. Because I don't want to say something they're like, that's not what we said. And so like I always just want to represent that well.
Thank you for that, Tanya. I mean, Medicaid is a big, massive program. I've been here, I guess, over 25 years, and I learned something new every single day. And when I started out, I was on the customer service line. I actually answered the phone and talked to members. And that's where I learned a lot about the Medicaid program. That's where I would talk to a member and I would say, I'm sorry, I can't answer that question. Let me go find out. And sometimes it would take me a while. So anytime you're talking to anyone in the community, that you're back, and this MAC is a perfect setting for you to bring back any comments, questions, concerns that you hear, because that's what we want to hear. And we want to know where there's confusion. We want to know where there's something that we can communicate a little bit clearer, or where there are issues that we need to dive down into our policies and see what's wrong. So I think just by you stating that, you want to know the terms of things, I think you'll learn more on this MAC and back than you ever thought possible about the Medicaid program.
I possibly ever wanted.
And we're very glad you're here. And I think that so far you're doing a fantastic job, and I appreciate your willingness to help us improve the program and bring all of those concerns back to us.
Yes, and again, I really appreciate, Tanya, you bringing it up. I hope that any member of the MAC, and I'm sure Emily would say this about the MAC members at your meetings, that if terms are used in a presentation or a discussion, that you know, do not hesitate to say, I don't understand what you're talking about when you talk about X, or, you know, can you define that for me or something. Emily and I and a few other people that are on here are at a Friday group, and we have one person who spends her time, and it's so helpful putting things into the chat when a term comes up, literally in the discussion, and saying, you know, the acronym means so and so or whatever, you know, just not knowing. But I think the only way that we will know to stop using the jargon or to explain it is if you bring that up, and I hope you will feel comfortable in doing that. I also want to reinforce Commissioner Lee's, you know, bring things back from what you're hearing in the community. That's how we started talking at the MAC level about how do we get more information out to people? How do we reach people to tell them, for instance, about Medicaid and about the waivers? So, Zachary, you have your hand up.
Yeah, I just had a question about I know the legislature is, you know, going through the budget process now, and they had that initial budget that came out last week, which was the bare bones one.
Right.
So I'm just wondering how much room will there be of negotiation about changing some of these things? As I mentioned in the chat, I'm really concerned about the copay situation, especially for people with very complicated medical situations that have to go frequently to the doctor and procedures, and $20 every time is going to be really challenging for some of those folks. So I was just wondering, like, what's the plan in terms of lobbying and trying to get some of those things changed?
Well, the department doesn't lobby.
Yes.
I figured, but yeah.
So they provide information when they're asked to, you know, to present and so forth. But many of us on here are advocates, whether we're actually registered as lobbyists or not. I think actually the requirement for the copays is 2028. Is it, Emily? Am I saying that right, or Lisa?
Yes, that's
In the federal, in the state, I believe it's accelerated. The timeline's accelerated. And what we'll take back is there is a lot of confusion between HR 1 is the federal law, already been passed by Congress, already requiring states to implement. House Bill 2 is pending before the state legislature right now. And so where there are differences between the two, like the state legislation is asking things to be accelerated or to be done sooner. You know, that is where currently, as the commissioner said, we can't lobby, but certainly I think people should express their opinion with their legislators about how they feel of the changes between HR 1 and House Bill 2. We don't have any way to negotiate the federal law changes. They're done. They're going to be implemented unless Congress acts differently, and we don't anticipate that. But certainly the state legislation that, you know, that doesn't align with the federal law could certainly still be negotiated through, I think, hearing from the public.
and two, I think the one thing that I would add, if you want your voice to be heard, at the end of every MOAB meeting, they have a public comment period where individuals can come and talk for 3 minutes. So, and if you want your voice to be heard or someone else's, you can do that. And I want to real quick go back to Tanya's statement and about, wanting to know what she can do on it. I don't want anybody on here to feel like that they have to wait for a MAC meeting or a BAC meeting to bring issues and concerns to the department, especially if it is something that is critical that you think we need to know about. You can reach out to us, or you can reach out to each other too. But if there's you hear something in the community about somebody who is not receiving services, particularly if somebody is ill, they are having issues with their application, for example, we want to know about those. And while the MAC and the BAC is a very structured meeting, sometimes we may need to know something outside of these meetings. So just feel free, to reach out to the department in those instances.
And we have a slide toward the end with some of those links to different parts of the department that may be helpful to you. Emily, you had your hand up.
Yeah, thank you. I wanted to respond to what Zachary was saying about, how do we advocate around this, and what are some of the opportunities? I think it was helpful, Veronica, to, differentiate between HR 1, which the big beautiful bill, and House Bill 2, which has not passed yet. I think that's really helpful. And I agree that House Bill 2, as it's written, goes beyond what we're required to do federally. So I think we should all keep that in mind. Yes, we need to comply with the federal law, but we don't have to go further in certain ways, and it does. And so I think those are the opportunities to, walk it back to the federal minimum and to make sure that we're not making it more onerous to apply and to renew your Medicaid coverage. Or in terms of the copays, we could go down to $1 and still be in compliance with the federal law. $20, as you mentioned, is just going to be absolutely unaffordable for most people. And it's going to fall hardest on people with the most serious health conditions. And so Kentucky Voices for Health is going to be putting out some information primarily around the copays and the additional paperwork around the things that have already been brought up, that self-attestation, prohibition, the 6-month renewals, and the fact that, people would be found ineligible if there was any discrepancy in data sources, rather than being given the option to submit additional documentation and a few other things. And so I'll be happy to share that with the MAC and would love to, and of course our BAC members, and then would love to talk further. If people have more questions, just reach out.
Thank you, Emily. Eric, your hand is still up. I don't know whether it's up from before or if you had something else that you wanted to say. Okay, he may have stepped away. I think it was up from before. Any other questions for Commissioner Lee? That was a lot to cover, and we appreciate that. And you will be getting the slides afterwards, so that should help as well. All right, thank you very much. More from the Medicaid leadership, and we'll call on Senior Deputy Commissioner Veronica Judy Cecil to give updates on the Medicaid waivers and the waiting list. Are you doing that part?
And I am going to very smartly turn it over to someone who does a better job of that, and that is Carmen Hancock, who is the director of our Division of Long-Term Services and Supports. So I will turn it over to Carmen.
Thank you.
All right, thank you.
Good
Hello,
morning.
Carmen.
Good morning, Dr. Schuster. Good morning, everyone. Carmen Hancock, Division Director for Long-Term Services and Supports here at Medicaid. I'm giving an update on our current waiver numbers, as well as there was an ask for an update on the child waiver. So I think the first set of slides here is the child waiver update. So we can go to the next slide. We do have in the next slide current updates. So as you all know, the child waiver, Community Health for Improved Lives and Development, is our newest 1915C waiver. That brings us to 7 1915C waivers in our state now. We worked diligently to get this up and running by the first of the year, and that did happen. So all of our systems were live on January 1st of this year. We do have folks that are in the application process. We actually have 2 children. So that last bullet down there, we can bump that up to 2 child waiver participants have been approved. The application process is running very smoothly within our MWMA system. So everything that we've worked through at this point, including assessments, we've successfully conducted 1 assessment now also, and that worked very well through our assessment system. So everything that we have with the child waiver is up and running and looking very good so far. We are focusing right now on provider outreach, enrollment, training, certification, that sort of thing. Obviously, we have to build the provider base so that we can support these kiddos. We do have 2 waiver providers that have been certified. They're now working through the enrollment process. And we have 7 additional providers that are advancing through the certification process. Those providers are a mix of all of the services that are offered in the waiver. The child waiver offers 6 services. That's case management, community living supports, clinical therapeutic services, supervised residential respite, and environmental and minor home modifications. So we do have applications from providers across the state for every service that's offered in the waiver. So we do have a great mix so far of those applicants. I think I've covered everything on this slide. Yep. So we can bump that last bullet up to 2 approved and several more in the application process. So that's where we are with our child waiver. In terms of the waiting list, this would be wait list updates for all of the waivers. We can go to the next slide. Okay, so I think I do recall someone, I think it was you, Dr. Schuster, that mentioned the over 16,000 number.
Right.
So this table does show the current waiting list and the allocation of slots, as well as the funded slots for all of our 1915C waivers at this point in time. This is current as of Monday. So we'll skip over to the waiting list column, our ABIQ waiver, the child waiver, and then our Model 2 waivers. None of those have waiting lists at this time. Our long-term care waiver, that sort of popped up on us a couple weeks ago. It says 3 on the waiting list. We do have 4 slots available. We're also working through several more allocations. So we anticipate those 3 people to be off that waiting list and on their way to receiving services. I would hope by next week, but that should be dropping back down to 0. Our home and community based, or the HCB waiver, has 6,019 people on the waiting list. Michelle P waiver, 9,806. And the supports for community living waiver, or SCL, is 3,813 people on that waiting list. So you do get a total number there at the bottom. That's just a raw number from addition, the 19,641. But the unduplicated number, so the actual unique number of individuals that are on one of these waiting lists, is at 16,792. There is often the question, so I would just address it now. If you look at the second bullet there on the slide, we do develop an allocation plan to responsibly allocate slots throughout the course. Usually it's 3 to 6 months when they're awarded. Simply because we don't want to risk bottlenecking. We don't want to overextend our providers. So we do allocate slots over time as they're released. That would be, some people say, well, why are there so many available, but they're not allocated, they're not turned over. We just don't have the provider network capacity to handle the dump with 500 or 1,000 slots at one time. So we do allocate those over time. And we can go to the next slide.
Carmen, can I just interrupt you for a second?
Sure.
Can you go back for a second? Because can you just very briefly explain the difference between duplicated and unduplicated?
Yes, ma'am. Okay. So the 19,641 number, again, we've just added that column straight down. The unduplicated number means that each person in those buckets only gets counted one time. So in essence, if you were to just do a subtraction there are about 3,000 people that are on multiple waiting lists. But the 16,792 is only counting each person one time, no matter how many waiting lists they're on. And I'll get deeper into that in one of our later slides.
Okay, thank you. I just thought it might be helpful.
Yes, ma'am. This is our wait list by time frame. So based on the waiver program, on average, how long are people waiting for that slot to come available? So we have that broken out by year. And then down at the bottom is the maximum number of days that someone would be on a waiting list by waiver, and then the average. Okay, we can go to the next one. So, Dr. Schuster, sort of back to your question with regard to duplicated and unduplicated. 14.5% of people who are on a waiting list are on more than one waiting list. So that's where we get our duplicate numbers. So we do have plenty of people that might be on the HCB waiting list, the Shelby waiting list, and the SEL waiting list. So almost 15% people are on more than one waiting list. 31% of folks who are on a waiting list already are receiving services in another waiver. So for an example, we have many people who are receiving HCB waiver services, and they are on both the Michelle P and the SCL waiting lists. But they are actively receiving services already in the waiver. So that's 31% of people. And then additionally, if we take a look at the makeup of people on the waiting list, 94% of them already have Medicaid. And they're already able to receive state plan or other types of services. So that's a very small percentage of people who are on a waiting list and without services. So again, 94%, that 6,792 already have Medicaid and are already receiving services in some other form. And then we can go on to the next slide. Okay, and any questions on?
Yeah, let's see if there are any questions for you, Carmen. I appreciate it.
Yes, ma'am.
Does anybody have any questions about the child waiver or the waiting list for the other?
I'm sorry, I have a question.
Yes, Aisha.
Actually, I have more than one question. My first question is, how are you monitoring the provider capacity for slot allocations? Is there like a person who does that, a department, and how often are you checking on that?
The provider, but that really is direct conversations and feedback with the providers themselves. Other than that, I would need to go back and get a few more details about how we're compiling that information, what frequency, what the outreach looks like, and that sort of thing.
I can speak to that just a little bit. It also includes the ability to get the assessments completed in a timely fashion. So we meet, I'm Leslie Hoffman, Deputy Commissioner, Department of Medicaid. It also includes the assessments and ensuring the assessments can be timely. We work with our administrators of each of the programs and who completes the assessments for each one of the waivers. So, for example, we may meet with Dale and talk to them about how many they can complete. One thing that we also always talk about is the churn. So, if you allocated and we've got folks out there that are getting assessments, we are completing those as well as new ones that are coming out each time. So even though we say it might be 25, they might have 125 for that month because of the churn each month. So I would just share that as well, but we can go back and usually that's an executive decision. We make a recommendation, or we have the last couple of times with the Secretary's office, and we all make that decision together.
I also have a couple questions about the duplication of services, which I know you talked about. But I guess I'm wondering, I understand the concept of their name appearing more than one time, right? But if they qualify or feel that they qualify for more than one waiver, I feel like it shouldn't be like maybe we should be looking at things individually and not all of them at the same time, because I feel like when you're saying they're duplicating, it's kind of like you're saying that there's less need than there actually is. But if the people actually do need more than one or could get one or the other, would that still be duplication? Does that make sense?
It does. I think so. If we go back to, we're talking about 1915C waivers. a person, any one individual cannot receive services in more than one waiver at any time. So
Okay.
they would have to pick the one that best fits their needs if they qualified and if they were eligible for several waivers. Duplication is more of a, I'm sorry, because we talked earlier today about not dumbing things down, but making sure people understood. It's more of a like a statistical or a technical term. It's not negative in nature. It's not saying they're duplicating services. It's just more of sort of a count. Is this a duplicated or an unduplicated count of people? So that's not to infer that there's some sort of duplication in their efforts, that they're doing anything wrong. It's just a matter of showing you the difference between the whole number of people versus the actual number of people realistically.
Right. I understand that. I just wonder if it makes it seem like there's less of a need for some of these than there are. And in the same way, my next question was, you noted that there were 94% of people that already had Medicaid services. But if they are applying for the waiver, does not mean that they need additional services that maybe they're not already receiving?
Absolutely. And that's likely why they've applied for the waiver, right?
Right.
Yeah, of course.
Yeah, I don't think that it's not said, I don't think, Aisha, in a way that says, well, they shouldn't have been applying for waivers because they already have Medicaid. Everybody that's applying for a waiver needs additional services that are not offered in traditional Medicaid. On the duplicated versus non, I think of it in terms, if I had a magic wand and I could generate or allocate enough money to put everyone who's on a waiting list into a waiver, how many people need to be put into a waiver? That's
Okay,
the way
that
to
makes
think
sense.
about it. So we don't need to find funding for 19,000 some odd. We only need to find funding for 16,000 some odd, which is going to be hard. Does that make sense?
That does, yes, thank you.
Zachary, and then, I'm sorry.
Oh, Dr. Schuster, it's Lisa Lee. I was just going to ask if you think in an upcoming meeting, it would be beneficial to kind of outline the difference between traditional Medicaid and waiver services, particularly as it relates to eligibility and what services are in waiver that they don't receive in the traditional Medicaid program. Just a thought.
Yeah, I think that would be helpful. And if, yes, let's think about that for next time.
It would be beneficial for me too, even though I've been here 25 years, I learn something new every single day.
Yeah. Zach, you had, you
Yes,
prefer
I just
Zach or-
wanted to, so
prefer
my
Zach
son
or
is,
Zachary.
yeah, Zach is fine. Zachary
okay.
just covered my official ideas on there. Yeah, so my son was one of those people that was on duplicated. He has been on the HCB waiver since he was a year and a half, and he years ago we put him on the waiting list for Michelle P because he has Down syndrome. And actually Commissioner Lee helped me kind of resolve this when a slot did open up on Michelle P recently for him after being on the waiting list for 8 years. But what we realized, his needs had changed since what they were 8 years ago, and he has a lot more medical type needs now than what he had 8 years ago. And so we actually made a decision to stay on the HCB waiver because that's really what's going to meet his needs best in the years going forward. So now there'll be one less duplication because of him. So we helped a little bit on those numbers. Yeah, so
well, thank you for
just
sharing
happened
that,
to,
Zach.
yeah,
That
so
really
and
brings it
Commissioner Lee was
home.
great
Yeah.
about helping me with that, figure that out, and some other folks as well. So, but one question after going through that, I guess the history of the waivers of where there were these different kinds of waivers rather than just one waiver program for anybody with disabilities. I still kind of struggle with that a little bit, where you would have a range of services that would be individualized, because it kind of sets up this competition between them. And I see, especially with Michelle P, everyone's, oh, that's the best one. And what I've learned is like, they're just different. It isn't that one's better than another, but people don't think that. The parents don't. They think there's definitely that perception about Michelle P being, really the better one to have. And again, I think definitely I would like to learn a little bit more about that history of how it got set up where there were these different waivers rather than just one waiver program.
Yeah, good point. I would also say SCL is the only one of those waivers that has a residential component. So a lot of people start out with the young kids on either HCB or Michelle P. And then, you know, as they get a little bit older and they start looking ahead and they're getting older,
Yeah.
and you're looking ahead, so maybe you're going to need residential. And
Yeah, and we're on the waiting list for
with the
that.
waiting list for SEL.
Yeah, we stayed on the waiting list for SCL because that may be a need later on for him.
Right. Kent Gilbert has his hand up. Thank you, Zach.
Yeah, Kent Gilbert. So I have two questions. One, do waivers sunset? Do they have expiration times? In other words, we make an application to federal to be given a waiver? What's the horizon for some of these programs?
So they're typically approved for 5-year period. Yeah. And all of ours right now, including the new child waiver, I'm not gonna give you the exact date because I don't have it in front of me, but I want to say they're all out for like till 2029. So we've got a 5-year approval on all of those. But as we're approaching that time frame, we do have to resubmit our application. And it gets very meticulously reviewed again before we get approved for another 5 years.
And a new complication that you all should be aware of, because this is brand new. The state legislature last year passed House Bill 695. It requires us to get express General Assembly authority prior to us submitting a waiver for renewal. So we'll have to back up about 2 years prior to be able to present that at, the next session and get legislation that gives us even the approval to submit the waiver. If we don't have that, we cannot submit the waiver for renewal.
So with wait times exceeding 8 years and horizons of 5 years, we have a massive structural problem here. Are we getting better? I mean, over time, are we reducing wait times? Are we seeing changes in those average wait times? Does anybody track that?
It's a budget issue. We're never going to be able to address the wait list and wait times
It's money.
with the budget.
Yeah. Okay.
So Kent, you might remember, because we talked about this at other MAC meetings, that there was a tremendous advocacy push for the 2024 session, because that was the last time they did the biennium budget. And we had more placements authorized by the General Assembly than has ever happened before. It was 1,925. And they were allocated, so much the first year of the biennium and so much of the second year. And it was kind of discouraging. At that time, we had 13,000 people on the waiting list. And so we got, almost 2,000 slots. And now we have 16,000 people on the waiting list. Right.
And when you talk about the budget, all of these waivers have to be budget neutral.
Right.
That means that the amount of money that we pay for these services cannot exceed the amount of money that would have been paid if those individuals had been in a long-term care facility. And that's been not as scrutinized at the federal level when we submit our waiver applications. And there is a new, I don't know, I think it's actually in policy, it may even be included in HR 1, that when the waivers are submitted for renewal, the state is going to have to provide extensive documentation surrounding the budget neutrality piece of those waiver applications.
Dr.
I'm sorry.
All right, Leslie Hoffman, and I just would mention too that not only is there the process that Veronica was talking about with 695 and a renewal that we have to complete in order to complete each time to advance the next period, but we used to do a review of intense, in-depth, and sometimes they even came on site, CMS did, to review us for all of our quality assurance measures, which used to not look exactly like they do now. They drive everything by quality assurance data and measurement now. And so we went from a 3-year to now we have to complete that annually with our budget neutrality report and enter it each time with the numbers of specific key indicators that they ask for.
Okay.
Dr. Shuster, I have a question here.
Yes. Oh, Hi, this is Dr. Wright. I'm in my car, but I did want to ask a question specific to the recent placements of 3 individuals with high-level needs with autism in Kansas. Can you speak to the process by which those decisions are made?
Is that 3 Kentucky individuals who were placed in Kansas, or is that a Kansas specific policy?
No, these are Kentucky residents that are receiving services now for their individuals with autism from Kentucky.
Are these waiver kids? Are they kids or adults?
These are kids, and some actually 1 or 2 are adults. Yeah, this was recently aired on the local news channels here in Louisville, Kentucky.
So generally those decisions, depending on if the member is a child or adult, and in a waiver or not, those decisions are made by first assessing the capability of Kentucky providers to provide the treatment that has been identified, for the medical necessity of the patient. That's priority 1. And so we call around to various facilities to see if there is a local provider that can do that. If not, then we move to the next step, which is identifying out-of-state facilities or providers who have the capability to meet the need. It is completely driven by diagnosis and treatment plan. And, I think a lot of the conversation now that's been happening, both state and federally, is how do we grow local providers, so state providers who can provide the care that we're having to go out of state for. And so there's a tremendous amount of conversation around that and what can we do in state to keep those folks here.
And typically that is for children, because we can do that through the EPSDT, is early periodic screening, diagnosis, and treatment benefit. We can do that for children under 21 specifically, but it's never, we don't ever want to do that if we don't have to. We would definitely prefer to keep those children in state when we can. And we do, other than Kansas, there are other states that sometimes treat our children, such as Texas or Florida.
Dr. Schuster, Dr. Moyer have been trying to.
Oh, I'm sorry. I can't see everybody.
No. I didn't, I should do what you do.
Oh, you're going to have to wave a flag if you're in the room there.
I know.
Sorry about that, Sarah.
Waiver 101 question. How do people get off the wait list, or how do they move into spots? Is there a redetermination process like there is for Medicaid where they have to pre-submit, or?
So if they're on the wait, there's something very general communication every year that just says, hey, is this still you? Do you still want to be on the waiting list? They don't have to take any action. If their information is correct and they want to remain on the waiting list, it's a very passive process. So no action is required. They would remain on the waiting list until their number. So when that happens, then we kick into notifying them that your allocation has come up. You can seek out a case management agency. Then we do that full assessment. So for that first step of general eligibility, it really is more a matter of, do you have a psychological or psychosocial? Do we have the correct assessments and diagnoses on file that would indicate to us that you might meet criteria? But after that slot allocation comes up, then we go out and complete that full functional assessment to determine if they actually need level of care.
And what percent tend to actually meet that? Like, is it most tend to meet
The
it, or
vast majority.
okay, I was just curious. Maybe the wait list could be smaller with that. And then how do spots open up? Like, is there a redetermination process every year for people in spots to make sure they still qualify and still meet the needs and are
There
costing
is.
less than?
So each waiver has, except for Model 2, Model 2 is twice a year. The others have an annual reassessment where we reassess level of care, take a look at all the diagnoses again. Have there been any changes? But we do that full functional assessment to determine if they still meet level of care. If it's determined that they don't meet level of care, then they receive a notification that they no longer meet level of care. They don't get the waiver slide. We've mentioned churn earlier. So there is some churn from, month over month for people who maybe have passed. We can turn those slots over the next month. Or if someone received that allocation that, hey, now it's your time. If we go through the level of care process and then it's determined they don't meet level of care, they lose that slot and we can reallocate that the next month. So we do have sort of an ongoing churn of people who, in those scenarios where we can flip over the slots every month. Not to get too in depth, but there's not a lot of, if someone were to just stop using their services, move out of state, we do have to hold their slot for the remainder of the waiver before we can recycle it and turn it back over to someone else. That's CMS guidance because they essentially, their interpretation is that once someone has a slot, if they receive any services during the course of that year, they own that slot.
Did you have a question about the wait list too, about,
Or she answered, I was just trying to see if maybe, if, like the example we got on here, maybe the wait list could be smaller. If we were evaluating that, but it sounds like most people qualify anyway. For the effort.
And we have done outreach, even, in conjunction with our sister agencies, like with Commissioner Marks' folks, especially for people who are on like multiple waiting lists. If they're getting really close in one and, we will make those outreach calls and say, this is probably going to happen soon. Do you want to stay on all of these others? Do you still feel like you need to be on all of these waiting lists so that we can sort of, get them down a little bit? But even in that scenario, in real world experience here with Mr. Hart, no, I want to stay on that waiting list until my slot comes up. So,
thank you.
Yeah. Carmen, I had one question about the child waiver because I'm still trying to wrap my arms around it. How would you very simply describe the difference between kids that are eligible for the child waiver versus a kid who's going to be eligible for HCB or Michelle P?
So the child waiver level of care criteria is psychiatric inpatient, hospital level of care, or ICF level of care. So given those two, in comparison to say HCB's level of care criteria is nursing facility level of care. So inherently, we're talking about a different set of criteria that meet for those waivers in the first place. So your child waiver is really focusing on more complex and multi-system behavioral sorts of concerns, or those with an intellectual developmental disability that, due to the severity or the complexity of their needs because of their disability, are in spaces where maybe they've had lots of interaction with law enforcement, or can no longer attend school, or have been in out-of-home care. That's
There's a question in the chat about what is the ICF level of care? What does that mean?
Intermediate care facility for individuals with developmental disabilities. I think is an ICFI.
Yeah, I see it.
Yeah, the ICF stands for intermediate care facility, right? And those are residential facilities like Oakwood.
So again, with the waiver, what we're looking for, and one of the assurances that we have to make to CMS, is that the members who are enrolled in a waiver need a level of care that is similar to, or it looks like what they would receive in an ICF, an intermediate care facility, or a psychiatric inpatient hospital. So,
yeah,
but they can be served safely.
in the community. All right, thank you very much. And I will just point out that there's a whole slew of behavioral health waivers now that we didn't even get to, but we will get to those at the next MAC meeting. As a psychologist, and know with Commissioner Marks there, we're very interested in those because we've not had those waivers before, and they're just new and getting rolled out, most of them. So we will talk about them at the next meeting. The next thing on our agenda is the TAC recommendations. TAC, again, is the Technical Advisory Committees. We asked all of, I'm sorry.
Dr. Schuster, I'm sorry. Do you want me to present on travel rules or just?
Oh, I'm sorry. Yes.
No,
yes,
that's okay. The information is there, but I can do a really very quick, just touch base, and then
You are
if any-
very good at very quick.
Thank
So
you.
I'm actually looking at it, but it's not registering in my brain. So yes, please.
That's okay. And if anybody has questions, any member has questions, please feel free to reach out to me one-on-one. I'm happy to give you a call and talk through it. So next slide, please. So in December, we had 66,573 individuals who went through renewal, and then you can see where they fell in approval and termination. Next slide, please. And then this is looking at those across the age. And as you see on the left-hand side are those who are approved, on the right-hand side are those who were terminated as a result of the December renewal. And we're going to focus on that 0 to 18. Next slide, please. So for December, we had what you're seeing on this slide is on the far right are children who were able to be passively renewed. What that means is we were able to go out and verify all the necessary information that's required for a redetermination and able to approve them without anything else coming from the member. So you'll hear that called passive or ex parte, but it's our ability to renew them without them having to take any action. And as you can see, as is typical for any of our renewals, the majority are in that passive renewal, which is helpful because then you don't have to go through the back and forth of someone having to send in documentation. The middle one there where it says passive with RFI means we attempted that passive renewal through the trusted data sources, and there was just one piece of information that we needed just confirmation on. And so we sent them a request for information. That's what RFI stands for. And to get that information because we can't approve them without it. So that's why they're put in that middle bucket. Those generally do result a little higher with the termination, which is the color on the right, green. And the reason for that is because if the person does not respond, then we have to terminate them for lack of documentation and limited response. But on the other side, when you see the 961, that is because they sent the information and we were able to approve them. And then the far bucket, on the left, which it says an active renewal. An active renewal means that there's been some change in the child's case, and we're going to send them a pre-populated renewal form because we're going to need verification because we do have a change of circumstance that we're seeing, and it requires us to send them that. We do populate that renewal notice with as much information as we have on file. So all they have to do really is just confirm the information, but sometimes there is additional documentation needed. And when you see those two numbers, the blue being the active means they did respond and we were able to determine them eligible. And then the bucket of those who were terminated are both, they sent the documentation and they were no longer eligible or they did not respond. Next slide. These are the reasons, as we just talked about, for terminations. And like I said, the majority of those are because they did not respond. We do find that a lot of families or guardians will not send back the information because they think they're not eligible, then the child's not eligible. And so we do try to encourage folks to understand that the child's eligibility is different. There's a higher income limit for children than there are for adults. So we always try to tell them, please send it in so that we can make that determination. So we certainly don't want someone to go without coverage without us making the determination. And then the middle bucket there and the ineligible benefits means they actually returned the documentation and we made a determination of ineligibility. And then the bottom bucket, the other reason, the majority of those are because we've been requested to disenroll the child. A lot of times they moved out of state or they've moved to a parent's private insurance or they've got coverage some other way. So those are the primary reasons. We do a lot of outreach before the end of their renewal date to try to contact families and encourage them to send the information in. We text them, we call them, they get written notice, we send emails. So we really try multiple times prior to the end of that month to get them to respond. But unfortunately, we continue to see high numbers of lack of response. Next slide, please. And there we go. I'm happy to take any questions if there's time.
Thank you, Veronica. I just want to say to the members of the MAC, and particularly the BAC members, one of the real services you can perform for your community is to remind people to keep their contact information up to date with Medicaid. So if you know somebody who is on Medicaid and has moved, ask them if they've notified Medicaid that they have moved or they have a different phone or whatever. And the other is that really important thing that kids very often are eligible even when their parents are not, because they do have a higher income limit. And we know that so often when parents lose their coverage of any kind, not just Medicaid, but health insurance, the kids get uninsured at the same time, even though they may have been eligible. So this is going to be going on how much longer on child renewals?
The full year, the 12 months will be over in June. When we restarted child renewals in July last year. So they're they are just going through their first renewal. And thank you for noting that, Dr. Schuster.
Yeah.
Because we had held them in advance during the public health emergency. And then our flexibility to hold them in advance was continued through June last year.
Okay, thank you. Any other quick question for Veronica that anybody has?
And just one other note, we have a really good toolkit on our website. We'll put that link in the chat for child renewals. So if you're out there in the community, there are posters and flyers that have the information about how to get help for a child going through renewal. And there's frequently asked questions in there as well to try to help explain to families about the child renewal process.
And you have those in English and in Spanish, right?
We do.
Yeah. Okay. Thank you. So again, you've got some tools there if you want to be helpful around that. Thank you. None of the TACs had any recommendations, so we don't have any recommendations. We also asked if any of the TACs had any key items that they've been dealing with that they wanted to bring to the attention of the MAC. And so I am taking advantage of that. As I said, I've been chairing the behavioral health TAC since it started, which I guess is a dozen years ago. And we have two issues that we have just really gone round and round and round about. The first is the quantity and expansive requests being made of providers by the MCOs in the form of pre and post payment audits. Even with the resumption of prior authorization in late June, early July, there continues to be a significant number of audit requests sent to various behavioral health providers, which necessitate the provider agencies to allocate significant staff time, energy, and cost in pulling numbers of patient records, copying them, making them available to the MCO auditing entity. We have discussed this at every TAC meeting, and we meet every other month since May 1st of 2024. So we've been talking about this for a long time, folks, and we appreciate very much the participation of the DMS staff and the help that they have tried to offer. But we are concerned that in some instances, it appears that the MCOs have violated their regulation timetables and have insisted on information being supplied by the provider in the initial submission or in response to audits that are not required to be submitted via the regulations. So I'm hoping that some other TACs whose chairs may be on this, or some other organizations who are represented here on the MAC might reach out to me, because if you all are also dealing with the problem of audits by the MCOs, I think we ought to get our acts together and talk about it, not just about behavioral health. I would hope that it's not just focused on behavioral health, but I would also like to know that. And again, we appreciate DMS staff providing information, and we continue to put it on the agenda so we can try to, my agenda item the last time was how can we improve communication between the MCOs and the providers so that we can work through this problem. The second one is the credentialing of peer support providers. For those of you who are not familiar, a peer support specialist is someone who has lived experience, in our case, either with mental illness or with a substance use disorder, or with both, which happens with co-occurring. And they get training, and then they get certified to provide services that are reimbursed by Medicaid. And they are invaluable, absolutely invaluable services, particularly with people who are just diagnosed with a mental illness or substance use disorder. I mean, imagine that you have been struggling and struggling and you just got a diagnosis, and then you're like, what does that mean? And you've got somebody who's kind of holding your hand and saying, I've been there. I know what it feels like, and I can help you, and I can go with you to your first provider appointment. I can tell you what this form is all about. I can tell you, whatever. Our problem is that a bill was passed, House Bill 505 in the 2024 session, that moved the certification of the substance use disorder peers over to the licensing board for alcohol and drug counselors. And the timeline for all of that to happen, unfortunately, passed on January 1st of this year. And we have tons of people, peer support specialists, who are somewhere in the process and have not gotten their certification completed. So they are not able to be paid by Medicaid. Their employing agencies are trying to keep them employed and giving them other things that they can do until this can get worked out. And the Department for Behavioral Health, Developmental, and Intellectual Disabilities has done certification for a number of years and continues to certify the mental health providers. But so many people have co-occurring disorders that we feel like people probably need to be certified in both areas. So House Bill 470 was just filed by Representative Moser, and the most important thing that's in there is that it would extend this deadline to January 1st of 2028. It does have an emergency clause, which means if the bill gets passed by both chambers and signed by the governor, it goes into effect immediately. It doesn't have to wait until mid-July when all the other bills that are passed in the legislature. So I bring that to your attention in case you are particularly interested in this and want to talk to any of the legislators about how important House Bill 470 is, because we really do need to get this solved. And that is my report. And Emily, you said, I'm sorry, that you had a recommendation.
Yes, I mentioned it in my report earlier, and I
Right.
put it in the chat, just that there be a policy change so that waiver participants do not lose their waiver due to actions of an employee or representative.
So thank you for making that. Does that need MAC acceptance?
No,
Do you
those
think?
recommendations from the back go straight to DMS. So DMS
Okay.
is Emily working on the response as we speak.
All right, well, thank
Okay.
you. Sorry, I didn't understand that that was different.
Yeah.
I'm used
No,
to,
no, totally fine.
I'm
Absolutely
used to the
fine.
consumer tax recommendations.
It makes complete sense.
Is the consumer tax is not meeting separately anymore, right? Okay.
No, I think we're just kind of paused indefinitely. If ever the Beneficiary Advisory Council stops meeting it or is no longer, if it's disbanded for one reason or another, then the consumer tech could resume meeting. It's
Okay.
still in statute and regulation.
Yeah. So just for the edification of the MAC members who are new, there are 16 TACs. I am told by our Medicaid staff that Kentucky is lucky we have so many TACs. And they range from, as I said, behavioral health, children's health, dental, home health, hospital care, persons returning from incarceration to society from incarceration is one of our newer ones. And we do have a reentry waiver we'll talk about next meeting. So pharmacy, physicians, primary care, OT, PT, and speech. So those TACs set their own agendas and so forth. They have, they're in statute. That's how they got to be formed. And the groups that make up their members, some of them are from one single association. Others are nominated by different associations is also in statute. And so as I explained earlier, they have to bring their recommendations to the MAC. I guess I should ask, does anybody have any questions for my report from the behavioral health TAC? That may be more in the weeds than you all needed to know, but when you've spent 18 months dealing with audits, you get a little tired of thinking that you're never going to get any progress. So, and the peer support specialists, we've really got to get those people certified or give them a chance to be working until they get certified. Because they're very valuable parts of the behavioral health system. Our new business item is one that, and it may be moot because this was going to be on our July 2025 agenda. And it's that up until that time, the 2024 telehealth fee schedule was the only one that was posted. So I guess my question of DMS is the 2025 fee schedule for telehealth, is it posted?
Do we have somebody from healthcare policy on that can answer that question? Apologies, Dr. Schuster. We weren't sure what the new business was related to the
Related to the fact that it said 2024 telehealth fee schedule. I should have thought to reach out to you all. If you could get me an answer to that, I would hope at least the 2025 has been posted and that people are being paid the 2025. And then I guess my follow-up question would be, when should the 2026 fee schedule be posted? Can I give you those two questions to take back to your folks?
I've got those two questions. I will say, when Medicare releases, which a lot of our rates are dependent on Medicare, when Medicare releases their fee schedule for the next year, it's generally towards November, sometimes December when we get it, which means it takes us time to pull it down, to evaluate it against our current schedule, make the necessary changes, plan for those system changes as a result, and then calculate the budget impact, and then move forward with approval and posting. So as you can imagine, that takes us probably at least 90 days to even get through the process, which is why often we are behind in posting it. And then we generally, every fee schedule is different, but we generally retro it back to January 1 once it's posted. So every fee schedule is different. Again, I apologize, we don't have somebody on that can speak to the fee schedule changes and what's posted right now, but we'll certainly take that back and verify.
2025 is on.
Thank you. Kent Gilbert has confirmed the 2025 is on there.
Thank you, Kent. So 2025 is
Good
posted.
to be a staff.
All right. We may make you an honorary DMS staff, Kent.
We need
Thank you.
support. We appreciate that.
So then we might look for 2026 in April or May or something like that.
Yes, we really do try to get them posted as soon as possible.
Yeah.
The behavioral health is always April, on or around April.
That's what I was thinking. That's why I was thinking that it would be.
Yeah.
But
The
behavioral
rest-
health is probably a little bit more complicated than the telehealth. I don't know. Maybe not.
It is, behavioral health is, it takes a lot more time for us to review the changes.
Yeah.
And I should say that behavioral health 2025 is posted. There is not even any entry for telehealth separately. So that may or may not be helpful.
So was there a separate telehealth fee schedule?
I did not want to speak without being 100% sure. I do not believe we have a separate telehealth fee schedule. The telehealth codes are embedded in each provider's fee schedule. But I did not feel comfortable in confirming that because I was 100% sure.
Well, you could tell how long I've been out of practice. Nina usually knows everything about telehealth, so I'm looking at you, Nina.
Just that Medicare came out and said that they were continuing to authorize telehealth until 2028.
Yes, they did,
Yeah.
and we are aware of that, obviously, but I don't think there's a separate telehealth fee schedule.
Okay, so it ought to be in the behavioral health fee schedule.
Yeah.
Okay. Well, that is very good news that telehealth, I mean, for the people on the MAC, telehealth has been the real breakthrough. Obviously during COVID, it was the lifeline, as Dinah will tell you. Dinah's with the Hospital Association. But every behavioral health provider will tell you that that was how people got their services. And it has continued, particularly helpful for people in rural Kentucky because of the transportation problems, although not all of them have a good internet connection to make use of it. So, and it doesn't work for everybody, you know, obviously if you're trying to see young kids or sometimes some of us older folks don't do so well with telehealth and the technology and so forth when there are language differences and so forth. But it really has been so I'm delighted that they've extended it to 2028.
Well, and think about this weather incident that we've had for the
Yes.
last weeks. Telehealth has stepped up to be a significant provider of care because people couldn't get out of their house.
Yeah, absolutely. So do we have any takers for the public comment? Helen, have you been monitoring that in the
We
chat?
have been monitoring, and I have not seen anyone sign up or request to be included. So no, we don't have anyone today.
Oh, well, I'm disappointed. I would have liked to have heard
So
from.
one moment,
In the room?
Yeah, we're here, we're in the room.
Oh, okay, thank you. Sorry, I couldn't track that one.
So we have someone in the room. I'm sorry. I'm having a little trouble.
I know,
Okay.
we're actually here in person.
Yay.
Okay, can you come forward and tell us your name and you have, Helen, will you time, 3 minutes or so?
Okay.
We'd love to hear from you.
Ready? Okay.
Yeah.
My name is Anna Shirley. I'm Courtney Hazlett. I'm actually peer support supervisor for a nonprofit organization for good school diagnosis. So we treat not just the addiction and alcoholism, but we also treat the mental health as well. So we came in person to the meeting. I know that Dr. Schuster had mentioned about the peer support and how that is being a big issue across the state right now. The numbers are pretty wild. The board process has been very lengthy for us. And so we just wanted to come in person and let you all know kind of our experience. We submitted our application back in August. We have successfully had 3 be approved, pass the test, and are now RADs. But we also continue to have 6 that are still pending. We've sent multiple responses to the board to try to get things set up. There's a lot of disconnect on communication about high school transcripts needing to come specifically from the high school. And there's no clear process. And with peer support, I'm a supervisor actually. So I kind of feel like we've been the key to helping them through this process because there has been no clear guidance. Getting underneath the credentialing board has been a really big process. So with that, we just wanted to let you know the situation that we face and our clients face. And Courtney, you can speak a little bit about how it's affected the clients and how we're kind of up against a battle of possibly not, provide that service. So. Yes, so obviously being peer support, I am a person who is in recovery, long-term recovery. And if it was not for my peer support, I was very grateful for my clinicians. I was very grateful for the medical staff. However, I remember being that client looking at my peer support and saying, I don't even know how to get 3 weeks clean. Sorry, I'm trying not to get emotional. How do I get years? Sorry, I apologize. So it was just it was a huge opportunity that became my role model, my drive for I wanted what they had. And it was actually my peer support who not just helped me in a facility, but also reached their hand out to me when they became that bridge. So obviously this is affecting us, but it's also affecting our clients because if I'm being transparent, I cannot count on my hands and I cannot count on my fingers how many times our clients have said, the clinical aspect is important before they learn about neuro and about their brain and how that addiction process works. Medical is there for medication, but peer support is the real life thing. And it's that sharing that experience, strength, and hope of we can do it too. And by us not being able to provide those services and or being able to be reimbursed because of the lack of communication between peer supports and the board, when we have done the process on our end, has been extremely difficult. So I think a big question is there any type of I don't know if I'm gonna say this right, but any type of this is obviously a barrier. And I don't know if, Medicaid has looked into or been open to, I know that the advocating of that date being prolonged.
Yes, so I thank you for the question and thank you for coming and speaking.
Yes, thank you so much.
It means a lot to us. It really matters. So thank you.
Yeah.
And being, personal about it. The problem is that this is a state law change. We have no control over the board or the law that changed. As Dr. Schuster mentioned, there is hopefully a fix on the horizon through House Bill 470, and that has an emergency clause. So if it can get through quickly, and sometimes legislation can, sometimes it can't. If it can get through quickly, it'll hopefully bring a remedy really soon. Until then, our hands are tied because we have in our what we call our Medicaid state plan, which is what is kind of like the book of how we have to do things according to CMS, the Centers for Medicare and Medicaid Services. And that defines who we can cover and how we cover them. And we can't do anything if something has changed at the state or board level. Because all we do is we cover them. We cover peer support.
Yeah.
And if the state law changes, instead of peer support specialist has to be X. And we don't, we have to follow that law. So we have no discretion just to continue to cover folks that don't meet the state law requirements.
So I guess the question is, for Medicaid, is there a solution to continue to provide the service without it being reimbursable? And if that emergency goes into effect, will those things be covered?
That's an interesting question. Yeah, does anybody know if 470 has a retroactive component?
I don't think it does, Kent, and I'm not sure that state law, I think it goes the other way too. I'm not sure state law can tell Medicaid what to pay for or what not to pay for in that way to make it retroactive.
Well, it doesn't have to, because it makes the effective date of that certification by the board a future date. So if that law passes, then anybody providing services today, I'm going to very strongly though emphasize it's at risk.
Right. Yeah.
But providing services today, if they push the effective date to, I think they've got January 1, 2027 or 20.
No, it's 28. They really put it out to give them enough time.
The
Yeah.
requirements to be registered by the board that is different from what Medicaid covers, then solve that problem for the current situation.
Okay, so
that makes sense.
Yeah, so that does sound hopeful for continuing to keep peer support. That we can take that back to the employers and say, hey, there's a solution possibly coming down the pipeline. These people can use in other positions possibly now, as opposed to termination, right? Okay. So that brings some clarity around that. What's kind of coming down the pipeline and how we can provide hope to not only our clients, but also to people who are in recovery who are really terrified about what these implications can be.
And again, I think this is another situation where the public's voice to their legislators really matters. I can tell you, we have shared our concerns, and to the extent we can, what the current impact is to the Medicaid program. But really, to make sure 470 gets out is kind of up to everyone else to make sure the legislators are supporting it.
Yes.
So, would appreciate your all's time.
Thank you
for your time today.
Can you tell me again what agency you're with? I didn't catch that.
So we are with Isaiah House.
Oh, okay. Yeah.
Yep.
Thank you.
Thank you.
And thank you for speaking up, and please don't ever apologize for getting emotional.
Thank you. I appreciate
it.
Thank you.
Yeah. You have the lived experience, and that comes with it, and that's what makes it so genuine and so helpful. So thank you very much. And thank you, Veronica. House Bill 470 is, as we speak, being heard in the Health Services Committee right now. It's still going on. That's why Steve Shannon is not present here today. So we will hope that it gets out of committee and moves along, but that's the bill that we really need to be advocating for. And I think that takes us, is there anything,
Yeah,
oh,
just
yes,
a quick
thank
question.
you. Yeah.
When it comes to that, you say once it gets out of committee, is that when we do the quote unquote most advocacy to get it passed?
You really want to advocate at every step of the bill. So
Okay.
if we had talked before, if we knew it was going to Health Services next week, for instance, I would have said to you, go on the Legislative Research Commission website, and you can find out who the members of that committee are. And you really want to talk to the members of the committee, because it's got to pass out of that committee before it can, or else it'll die. So it's in that committee right now. And
as us being on Mac and Back, does it hurt us talking to the legislators about it, or is there a way?
There's absolutely, from my knowledge, and never has been, because a lot of us on the MAC talk to legislators all the time.
Okay.
What you can't do is to say that you are speaking for the BAC or the MAC.
Exactly, but I'm just speaking for myself. As long
You
as I
are
don't
speaking
say
as
I'm
a
speaking for
citizen and
Dr.
a person
Schuster.
who's concerned, and you could say, am very familiar with the Medicaid program, or I'm very familiar with whatever. Yes, absolutely.
Yes, ma'am. Thank you
So
so much.
if it passes out of the committee, then it will go to the full House. So all 100 House members would, somebody posted the names of the committee members right there. Thank you. Kent, you're Johnny on the spot. We really will have to give you a salary. So let me tell you, if you've got paper and pencil, I'm going to give you the number to call, and you could call and leave a message for your member of the House. 1-800-372-7181. 1-800-372-7181, and Kent's put it in the. So that's to the switchboard, and they're open from 7 in the morning till 7 at night, I think, most of the days of the session. And the first time you call, it'll take you about 2 minutes to get registered. They'll ask for your name and your address and your phone number. And then anytime after that, you call and you give them your phone number, and they will pull you up and they'll say, "Oh, Tanya, you live at so-and-so," and you say yes. And they'll ask you 2 questions, well, 3 questions. They'll say, "What are you calling about?" And so you want to say House Bill 470. And then they'll say, "Who do you want the message to go to?" And you say, I want it to go to Representative Wilner, let's say, is your representative. And they say, "And what is your message?" And your message is, "Please vote yes on House Bill 470. Very important for people who have addictions or have substance use disorders," or whatever you want to say. And they will take that message down, and then they will either send an email to the legislator with your message and who sent it, or they will print out what they call a green slip, which is literally a green piece of paper. It's about half the size of a 8.5 by 11. And if you go in a legislator's office, you will find that there are all kinds of green slips everywhere. And that's how they kind of count votes and what issues are important. So it doesn't take thousands of those to get their attention. It really just takes a concentrated number of those calls. And if you're a constituent, in other words, you're calling Representative Wilner because you live in her district, you can say as part of your message, "I am your constituent," because that makes you even more important, because they're all running for office all the time. And that means that you can vote for that representative or senator. So if it gets out of the House, then it goes over to the Senate and it goes through exactly the same process. It has to go to the committee over there, probably will be Health Services again. It has to get out of the committee with a positive vote, and then it has to be passed by the Senate. And then it goes to the governor's desk for his signature or his veto, but we would certainly know that the governor is not going to veto this. Does that help?
Yes, you are very wise and knowledgeable. So very, very helpful. I call them often. Most of the time, before I even finish, they already got my address pulled up.
Yeah.
So that lets me know they remember me a little
That is
bit.
absolutely right, Tanya. In fact, when I do my advocacy training, I always kind of joke and say, I don't know what medication those switchboard operators are given, but they are the most helpful, most pleasant, most patient people I've ever talked to or heard. I've never heard anyone complain that they were treated rudely, quite frankly. I mean, it is amazing. And they will help
They
you.
deal with a lot. They definitely could deal with a lot. So to have the patience they have and when I ask questions or if I'm confused about something or how to articulate it to the best, they're very helpful. They take extra
And they'll help
time.
you find the bill too if you don't remember the bill number. Most of the time they can help you with the bill number. And sometimes they can help you with, who your senator or your representative might be. Well, I'm preaching to the choir here, Tanya. I'm so glad you're a regular. I know Peggy is. She just put that in the chat too. So, but that's how your voice gets heard. Absolutely. So I think we will call the meeting to order since we ran about 25 minutes over, but I hope that this has been a positive meeting. Please give your feedback. And I will be certainly well before the April meeting back in touch with you all to get your ideas for agenda items. We definitely want to come back to the waivers and get some history and get some understanding about how eligibility for Medicaid is different than for the waivers and so forth. And I want to hear about the behavioral health waivers at the next meeting as well. But if you have other ideas for the agenda, please let me know. And I thank you all. I thank our ex officio members for being here. I think the DMS staff certainly, who are always helpful. And Helen and her folks with Alterum. And then Barbara Wash, who is our go-to person who keeps us on the straight and narrow, as I say, and helps with the all the logistics and so forth. So thank you all so much. And we will definitely see you on April 2nd. I'm glad it's not April Fool's Day. We'll see you on Thursday the 2nd. Stay warm and stay safe. And we will adjourn the meeting by acclamation. How's that? Thank you.
Thank you.
Yes.
Thank you.
Bye.
Thank you.
Thank you.
All right. Bye-bye.